Go on to our next case, Dr. Nilesh Kumar, who's a consultant at Lotus Eye Hospital and Institute, senior consultant, and he is going to be showing a small pupil situation.
Thank you so much, ma'am. One small correction. I have now started working at my own setup. It's
Yes.
Madhvi Netralaya.
Madhvi Netralaya, where is that?
Yes, ma'am. In Bihar, ma'am.
Oh, very nice.
And thank you so much, ma'am, for this opportunity. I'll just share my screen.
Yeah, fine.
So we have got a 60-year-old eye with small eccentric pupil and white cataract. What should we do? Shall we use intracameral adrenaline? Shall we do stretch pupiloplasty?
Can you increase the volume?
Should we do sphincterectomy? Shall we use iris hooks? Or my favorite, BX ring? Let's see how the surgery proceeds. So we make the side ports and the main incision, and then the first thing we do is inject intracameral adrenaline, but it has no effect. Then we stain the capsule using the trypan blow by going below the pupil margin and then wash with BSS. Then we inject viscoelastic that goes below the pupil margin, below the pupillary plane to elevate it from the capsular bag so that the BX ring goes pretty well inside. The first flange goes directly below the pupil margin. The second flange is then engaged into the pupillary margin. But when we start engaging the third flange, you see the iris is being pulled towards the main wound, and that can lead to iridiolysis. So what we do? We use crutch forceps to do a stretch pupiloplasty so that we have some space to engage the third flange. So now the third flange is being pulled and then negotiated to place it below the pupillary margin, and now we have the BX ring in place. So now we inject BSS again and start with capsulotomy. Just as we relax, we see the capsular excess forceps engages the third flange and dislodges the BX ring. Now what should we do? We start again. We inject the viscoelastic, disengage the entire BX ring, and then renegotiate it below the pupillary margin, keeping in mind that the flange do not engage the capsular margin so that we don't have a torn capsular bag. So now the BX ring is again repositioned, and now we start with our routine phaco. So we do a hydrodissection, the nucleus is rotated, and then we proceed with a mix of vertical and peripheral chop. So we divide the nucleus into two parts from both ends, and then we take out the heminucleus and emulsify it, and then rotate and take out the second heminucleus, and then the epinuclear cleaning starts. So everything has to be done in the central safe zone, as that is the area visible, and we should try to avoid and go beyond the pupillary margin. Now this is something I learned from my father, to hydrate the main wound so that we don't have an iris prolapse when we start cortical cleaning under high flow. But when you're in the flow of the surgery, sometimes you tend to forget what you are taught. So in the flow, I just go from the main wound to disengage the cortex, and now when I enter again, I have an iris prolapse. But BX ring is there, so it is holding off most of the iris below, and I have only a minimal amount of iris prolapse, and that is quite helpful. So then I again reposition the iris, put in the visco, and then inject the IOL. But as the luck have it, I haven't flipped IOL. So then again, using Tosinski hook, I flip the IOL back into the position and put it inside the bag. And now the time is to disengage the BX ring, quite routine manner. Disengage one of the flange, then hold from one of the vertices and pull it out. So it's very simple to disengage it. And then I start with viscoelastic cleaning, minimal amount of iris prolapse because I was doing in the low flow now. And then I hydrate the main wound, and everything looks now that went well. The patient on the first POD was very happy, minimal amount of glare and a vision of 6/9. Thank you all for your time.
Yes, Nilesh, that was truly a wonderful video.
Thank you so much, ma'am.
It really talks volumes about your skill set. But then there were some issues about the BX in this particular case. So what would you want to add here, Dr. Suved? Does it mean that small pupil and shallow AC? That's one situation where you could consider iris hooks too?
Yes, the two situations where I would definitely consider iris hooks is one is a subluxated cataract. Shallow AC is not such a big deal. Subluxated cataract is a place where I always consider iris hooks because the ring is very thin. It's thinner than the hair. It's 75 microns in thickness, and using a 23 gauge forceps, which is zero 0.5 millimeter in dia. So it's and 0.6 rather. So it doesn't make a difference over there. So if you have a 1 millimeter AC depth, that's good enough for a BX ring. And then you're going to inflate it anyway with a little bit of viscoelastic. As far as this case is concerned, congratulations, Nilesh. Very well done. Only thing I think there was a little bit of an assessment. What I recommend always is before we start off with the device, we need to assess whether it's a rigid pupil or an elastic pupil. So there, though you showed very elegantly how to manage it. So if you had an assessment that it is a rigid pupil in the beginning itself, you would have done a stretch pupilloplasty with 2 Coughlin hooks, and that would have given you a much more better cosmetic pupil. See, the circular shape of the pupil would have been there. Nevertheless, once you're stuck over there, once you've got 2 flanges in, this is the way to go. Or you'll have to disengage the ring again and do the stretch pupilloplasty, and then re-engage the BX. So either way, I think it was pretty well done.
No, there is another way which I am doing it right now. So when I've told you that also, see when you have 2 paracentesis, when the first thing is to stretch it a little bit, because this iris, this is not the regular kind of small pupil. This iris is thin, atrophic kind of pupil and all those. So this has to be stretched a little bit, not too widely. It has to be just stretched so that you get few small sphincter tears here and there, so that it becomes slightly loose. And the third one, when you engage, use the one paracentesis to hold the ring, and from the second paracentesis, use a Coughlin hook to retract. So you will need to stretch only halfway. One half the hook goes, the second half the ring goes. So you don't have to pull it drastically away. And the iris also, you don't have to retract too much.
Yeah, bimanual technique.
Bimanual. That is the best way to tuck the iris onto the ring when the last one seems to be a little difficult. So rather than pushing it widely towards one corner, either with the forceps or with this one. So in this case also, the ideal one which I would use is the ring, because this is not a very shallow. My shallow chamber problem is with intumescent lenses. Intumescent cataract with very fluffy nucleus inside, and the very, very intumescent ones, I would definitely like to have a little larger kind of a pupil so that I am comfortable doing the rexus close to the pupillary margin. That is the only reason for a shallow AC. Otherwise, shallow AC is not an indication for me to use hooks. And here, definitely, this one was a good option. And engaging it during a rexus and all is a technique issue. That can be avoided by perfecting your technique while doing it. And iris prolapse, actually, rings do not prevent iris prolapse. So if you want to not have iris prolapse, have tight incisions and longer corneal incisions in the main incision, and don't let the paracentesis and all leak. So if you have leak, it will come up into the incision even if you have a ring there. So that is known.
In a very floppy iris, keeping the hooks, I'm so for the hooks.
Yes, if it is a very floppy iris and if it keeps coming out, you better put a very small kind of incision longer into the cornea and try to avoid this. But otherwise, have your hook underneath or just next to your incision so that it can be pulled towards the periphery and avoid it from prolapse.
Dr. Chitra is so technologically advanced and still sticking to iris hooks. That's a little bit of a conflict over there. So anyway, coming back to what Minu said, I would yes, agree with him, and I keep advocating this, that iris hooks or pupil rings do not prevent iris prolapse. The iris prolapse depends upon, like Minu said, one is your incisions, and second is the extent of the floppy iris. Floppy iris has different severities. So if it's a severe floppy iris, it's going to come out irrespective of what you try and do. Okay, so even if you have long incision, side incision, it is, after all, you're going to use some fluidics over there and do the surgery. So the extent of the floppiness of the iris, it may be a good day, a bad day. So how floppy the iris is makes a difference. What the ring or the hooks give you is a constant pupil size to finish the surgery. You must understand that.
Just one point, can I add?
Yeah. Yes. Devashish, I need your support.
No. The thing is, whatever ring you are using in a pupil which is rigid and which is very small, you need some minimum amount of stretch pupilloplasty to be done before you insert the rings. Shubhendra, do you agree to this?
Yeah, of course.
Exactly, of course.
You need it for even iris hooks, you need it.
Yes.
But for a floppy
But
iris,
not-
you would not do a stretch pupilloplasty at all. I wouldn't advise triggering it off at that point.
You
Just
see,
sufficient to
No,
put
madam,
it-
not for floppy iris. Not
Yes.
for floppy iris.
see, a floppy iris is technically elastic pupil.
Elastic.
Okay, so you don't need to stretch. We are
Yeah,
talking of two different things.
yeah.
So a floppy iris, by definition, is an elastic pupil.
Mm.
But the question is, nothing prevents you from having a combination of different types of pupil.
Mm.
Okay, so in a floppy iris, you really the pupil which was 7 millimeters and has come down to 4. It was obviously it had dilated to 7, so you don't need to stretch that. And if it's elastic, and you have a very simple test for doing that, is as soon as you've made your paracentesis, just inject a little bit of BSS or RL, whatever you're using from the side port. If the pupil expands a little bit, as the AC deepens, you know it's an elastic pupil. If it doesn't, it's a rigid pupil. So you go ahead. Now, how you choose to tear the pupil is your choice. Whether you're using 4 iris hooks, 2 Kuglen hooks, or a Malukin ring, or a APX, or a I ring, or a BX. Now, BX is not strong enough to tear it, so I always recommend that you use a stretch. When I say stretch pupil, it does not mean limbus to limbus.
Yeah.
It just means make it about 5 millimeters. That's enough.
Yeah.
Exactly.
Wonderful,
And regarding
wonderful.
recurrent iris prolapse, at the site of the iris prolapse, if you put in, even if the ring is in place, if you can put in one iris hook below the incision site, you can allay the recurrent iris prolapse, which is annoying you so much in the surgery.
Yeah. And what about the role of using topical atropine pre-medication? Would you all of you advise that in a floppy iris situation?
What topical what?
Atropine.
Atropine drops.
Atropine.
No. I don't think atropine helps in any way in floppy iris.
Yeah, when the iFace was described initially,
Hmm.
there was this feeling that pre-op atropine priming the iris for a few days would help. But I don't think anybody uses it now, and I also personally feel that it doesn't cause much of an effect.
Okay.
I also don't use.
The use of dispersive viscoelastic like viscoat, no financial interest, is very, very important in iFace. The moment, just like you were talking about recurrent iris prolapse through the wound, if you can just put in some viscoat at that area and push the iris away from your wound, it remains there for quite some time. 2-3 times you may have to reapply it, but it goes a long way in preventing recurrent iris prolapse. And like Suven said, the rings do not, prevent a prolapse. But one thing that definitely prevents recurrent prolapse through the main wound is one subincisional hook. So either you use 5 hooks, make one of them subincisional, and that definitely prevents iris prolapse.
Yeah,
Right.
very good. That was a nice